Good evening, everyone, and welcome. My name is Irina MacArthur, and I'm Director of Patient Experience at Inception Fertility, and I'm really glad you taken the time tonight to join us. Tonight, webinars is focused on men and infertility, a topic that doesn't talk about nearly enough. Infertility is often treated as a medical issue alone, but for many men and their partners, it also brings emotions and challenges with the relationship. We'll be spending some time not only on what men is experienced, but also on how partners can support one another through this journey. Leading tonight's discussion is Dr. William Patok, psychologist and clinical associate professor at Sydney Kemal Medical College of Thomas Jefferson Institute, University. I'm sorry. So Dr. Patak will spend many years working with individual couples and help them to navigate infertility and help them to make sense of both emotional and relational impact of this journey. He will be joined by Dr. Ali Domar. She's also a psychologist and Chief Compassionate Officer for Prelude Network. We'll have time for questions at the end of the webinar, and we really encourage you to submit them as we go. Please use the Q&A portion for that. We also encourage to ask question live, so please raise your virtual hand and I'll unmute you and you can ask the question directly. We'll dedicate plenty of time at the end of the webinar for Q&A session. So thank you once again for everybody for being here, and I will turn over to Dr. Patak.
Thank you very much. It's a pleasure to join all of you out there and to be with my colleague Ali Domar for this program. Irina, if you would click on to the next slide, please. So there are a tremendous number of myths about men and infertility. And one of them, excuse me while I fix something. There we go. I got my screen good. So one of them is that infertility is exclusively a female problem. And this myth has arisen for a variety of reasons. If you go back to biblical times, there's plenty of infertility in the Old Testament, but it's always with the women. And there's never an indication that a man has any problem helping his wife to conceive. Secondly, another myth is that male infertility is linked to sexual problems. In other words, the reason a man can't help conception is because he is sexually inadequate in some way. And of course, this is not true. A man can have excellent erections, have powerful ejaculations, but the sperm that he's ejaculating isn't capable of helping conception. A third myth is that men don't care about having babies. And that may be from a variety of reasons. One of them, and I'll talk a little bit more about this later, is that men typically don't talk about having babies. And there may be other reasons as well. But it's really not true. Men do care about having babies, and I'll share some of the research with you in a minute. Another is that men don't have emotional reactions to an infertility diagnosis. When you talk to men who have been diagnosed, you find that they have very extensive and very powerful emotional reactions, just in the way that women do, except expressed differently because we are different. And finally, men won't talk about their feelings. Sometimes this is men don't have a vocabulary to talk about their feelings. Other times it's that men don't have the opportunity to talk about their feelings. And it's not that they won't. It may also be that they're not in social situations that encourage it, quite differently than women who frequently are in situations which encourage talking about feelings. And my suspicion is that there are other myths out there, and you may have heard some of them. And if you do, please put them in the chat or bring them up as a question later on. Could I have the next slide, please? So I want to give you some facts to sort of contradict those myths. So first of all, men over the age of 35 are twice as likely to be, oh, I need to turn my phone off. Excuse me very much. Thank you. Sorry about that. So men over 35 are twice as likely to be infertile as men under 25. Now, in a lot of ways, this makes sense. It's not quite this comparability with female infertility, where we know that at age 35, there is a significant decline in female infertility. And that has to do with the fact that a woman is born with all the eggs she's going to have, and there is a significant drop off with the number of eggs available as time goes on. Men continue to produce sperm throughout the lifespan unless something happens. But over the age of 35, and I'll talk a little bit more about this in a second, there are changes in sperm quality that are potentially result in infertility issues. We know that the genetic quality of sperm declines with age. In fact, DNA fragmentation increases beyond the age of 45. Most semen analyses don't necessarily talk about DNA fragmentation, but what happens is on chromosomes, little pieces of DNA don't quite form properly. There are fragments that are missing, and this can really have an impact on conception. The number of men who are infertile or subfertile in the United States is about 2.5 million men. So that's about 10% of the men who are trying to father a child at any given time. To give you an idea about how many men seek help from infertility clinics, in the data from SART, which is the Society for Assisted Reproductive Technology, shows that in 2022, which is the last year for which there's validated data, 41,531 babies were born via IVF. 7,345 were born from donor sperm. That's about 17% of those babies. That does not count babies born through intrauterine insemination, only babies born from IVF. So it's a very significant number of men who have had infertility problems, but have used donor sperm and are conceiving and bearing children this way. Next slide, please. So when you get a semen analysis, and most reproductive endocrinologists would want that to take place fairly early on in treatment for a variety of reasons, not the least of which is that in terms of cost, it's relatively low. In terms of invasive nature, it's not invasive at all. So it's relatively easy to get a specimen. But a normal concentration would be about 15 million sperm, or about 39 million in a normal ejaculate of about 1.5 milliliters. It's important for there not only to be enough of the sperm, but they have to be able to move forward. And so normal semen analysis says about 32% have if you have 32% with progressive motility or higher, in other words, they go forward in a straight line, that's a normal evaluation. In terms of morphology, the shape, it's about 4%. So you need to have good looking sperm that go forward and there to be enough of them. And of course, the ejaculate has to have a pH of between 7.2 and 8.0 so that the ejaculate is compatible with the pH that's present in the vaginal barrel. Because if it runs into a pH that's different, then there may be some conflicts and that will really reduce the quality of the semen. So all of this is World Health Organization data. The normal semen analysis doesn't necessarily give you DNA fragmentation. Now, you wouldn't ordinarily run that with a man under the age of 45, but you certainly would want to with a man over the age of 45 because the higher the rate of fragmentation, the greater the risk of some birth defect or lack of conception. Next slide, please. So this is the factory. This is where the sperm is created in the testicle, and it moves from the testicle through the epididymis into the vas deferens and then out through the urethra with an ejaculate. So there are a number of places where things could go wrong. And so something could happen with the testicle, something could happen with the epididymis, and something could happen with the vas. And we'll talk about those things in a minute. But it also means that if something is wrong further down the delivery line, the factory line, so the vas deferens or the epididymis, it would be possible to retrieve sperm earlier in the system. So, for example, from the testicle. Next slide, please. So this is what a semen analysis would show under the microscope what sperm look like. So on the very far left is a very normal looking sperm. It's got a nice oval head, it's got a neck, and it's got a tail. And now we start to everything from the going right from the left from the left is not normal. So if the head is too big, or if the head is too small, or if there are two heads, one case where two heads are not better than one, a single head and multiple tails, a pointed head, a head that's misshapen one way or another, all of those could create problems in conception because if it can't swim in the direction it needs to go, it's not going to get where it needs to go. So sperm, ability to swim straight, ability to have to look proper, and then to be there to be enough of them. Now it's true, it only takes one. And so for many procedures that are done with ICSI, intracytoplasmic sperm injection, you just need to find one good one. But that requires a very careful analysis under the microscope. Now, this is what the lab person is looking for. Good quality, that one on the left. Next slide, please. So there's a lot that can go wrong. So pituitary disease, something going on in the brain that is not telling the testicles what to do properly. The pituitary is a very small organ in the brain, which has a tremendous control over many things in the human body. And so some form of pituitary disease could interrupt the system that tells the testicles what to do. Androgen excess, too much of it, too much testosterone basically, can create direct problems. So so if you have low intratesticular testosterone, not enough, sperm won't grow, spermatogenesis. If you have too much, you create a problem because the system believes there's too much there, so it doesn't work to put any out. And one of the things that may be problematic is for men who are into bodybuilding and take steroids, anabolic steroids, they may throw their reproductive system off in such a way that they produce a fertility issue that could be reconstructed by going off of them. But if you do the testosterone based steroids for too long, you might throw your system so far out of whack that it wouldn't be able to rebound. There's also problems with sperm delivery. So a man who's born without a vas deferens, you'll remember that from one of the earlier slide, which is part of the delivery system. Well, if there's no way for the sperm to get into the urethra and out through the penis, it's not going to be delivered. Cystic fibrosis is a disease which could retard that or cause the CBAVD, or a man could develop something called retrograde ejaculation. And what that means is that rather than going out through the penis, it goes back into the bladder. And so the sperm gets destroyed and doesn't get delivered. There are other things which could go wrong. So certain medications could change sperm quality. Exposure to certain kinds of chemicals or radiation could cause significant changes in sperm quality. Other behaviors, spending a lot of time in a hot tub. The reason the testicles are in the scrotum is that they hang below the body because they need to be slightly lower in temperature than the rest of the body. Somebody who rides a bicycle an excessive amount could and doesn't have a seat which protects the system that delivers, particularly his testicles and his penis, could produce a lot of problems later on. So there are a lot of things that men need to be careful about if they are thinking about becoming parents through reproduction with their own sperm. And one of the things we don't do very well in this country is teach men about reproductive health. And I'll talk a little bit about that in a minute. The next slide. There are treatments, there are ways to get sperm that can be used directly. So there are microsurgical techniques where sperm is extracted from the epididymis um, or directly from the testicle. There are times when IUI, intrauterine insemination, is utilized if the delivery system um, works. So the sperm's got to be able to get out and placed in a um, catheter so it can be directed into the uterus and directed close enough to the ovaries so that conception can take place. In vitro obviously takes place outside of the body. These days I mentioned ICSI, which tends to be highly preferred by many labs because one sperm and one egg are combined under the microscope and you can actually see the fertilization taking place. A term which we don't talk about too much, artificial insemination by donor sperm, AIDS is an acronym, but we do use a lot. You saw the data before, which shows that over 7,000 children were born as a result of donor sperm in the year 2022. And then there's something called transurethral resection of the ejaculatory ducts. So going through the urethra, those ejaculatory ducts can be resected, and the sperm then is allowed to is able to bypass or get out. All of these are treatments. They don't. They are ways of retrieving sperm that's already there. There are other treatments that are truly not treatments. We're not producing more sperm, but research now is looking at things like when is sperm most active? So you could have, for men with low or subfertility issues, it could be that the sperm is most active and viable for conception between the hours of, let's make this up, between 10 and 12. But if you use that sperm between 2 and 4, there are components of it that would not work as well. And there is research going on right now is taking a look at those other factors to help with insemination. The next slide, please. So we're talking about men and we're frequently compared to women. Are there differences? Do men and women react differently to infertility? The common wisdom is that fertility confirms a man's virility. If he's fertile and he's capable of producing children, he must be a sexually active and virile sort of man. Um, Maybe that's true, maybe that's not true about virility, but fertility does not confirm it. You could be very strong. And in fact, those men who are bodybuilders and utilized steroids to do that could compromise their fertility significantly. But for many men, the loss of their fertility suggests that there's something about their virility and it can be very, very distressing to them. The notion that men desire children less than women, well, research suggests that infertility is less distressing to men than it is to women. But for men and women between the ages of 31 and 40, it's about the same. It's about as equal. Now, I think there are a lot of reasons why it may be less distressing to men. And I think one of those reasons is that for men, your fertility isn't confirmed by the way you look. But for women, pregnancy, which is visually obvious to pretty much everyone, confirms the virility, the fertility of a woman. There is nothing comparable with men. So you don't know if there's a problem. Um, so we guess, well, guys just don't care. But that's really not true. Many men do care a great deal. Next slide, please. Are there different impacts? Yes. Women report that they have reduced friendship contacts with their peers who become parents. Um, and that's because other activities can take over. Caretaking, domestic activities, career. If you're out of touch with your peers, with your colleagues, you may have reduced emotional support. There are certain cultures where if you've been married for more than 2 years and you haven't had children, you're assumed there's an assumption that there's something wrong with you, and you may withdraw from those communities. Um, Men seem to undergo fewer changes in friendships with other males because you don't know what's going on with him. And he's likely not to talk about how his fertility has had an impact on him unless he's with somebody who is really close and perhaps has had a similar experience that he knows about. So it's comfortable to talk about it. And for many men, the notion, with a male factor, the notion of holding up their partner becomes a huge responsibility. And he will feel guilty about the stress that he has caused his partner because he's not giving her a baby, he's not impregnating her. Next slide. Do men care about fertility? Yes. And as early as 84, McNabb was doing research and wanted to find out how men felt about their infertility. He had 500 subjects. 15 of them were willing to answer the questionnaire. Certainly too small a sample to say anything other than that these men who refused to participate or declined to participate thought it was too painful for them to talk about it. Mason, who was writing about 10 years later, did a survey with a bigger sample of men in Great Britain, and she got guys to talk about how they felt. And they were more willing to discuss it. And it was pretty clear that they had lots of feelings about the fact that they were unable to father a child. There's some specific self-help literature which has grown up over the years, and you don't get self-help literature written by one of our colleagues, Leslie Cover, and her colleague Thomas, unless there is a need for it. So by 2000, we were starting to get some books, and Marcia Inhorn, who is at Yale and has been studying the anthropological and cultural issues in male factor infertility, specifically in parts of Africa and the Middle East, has found clearly that men in those cultures have significant feelings about their fertility. There's been very little contemporary literature written about it. Michael Chabon wrote a book that dealt with a man's infertility. But for the most part, men are not writing about this. We have lots of women who've written about their own fertility. So we assume women care more. Lots of women talk about it publicly. So we assume they care more. I submit to you that it's because men have a hard time talking about it, not that they don't care. Next slide, please. So this is a video, and the gentleman is David Nail. He is a country and western singer, and that's his wife with him. Um, there are some things within this clip which is edited, which may be uncomfortable to hear, but it is a reasonable representation of a man who is willing to talk about his fertility challenges. And when it's over, I'll give you a couple of comments I have on it.
I can't hear it, guys.
Yeah, we're having trouble with the sound. I'll tell you what, Irina, let's not hold people up so we can get to the discussion part. And I'll just describe what David is.
Let me try again. Just
Okay.
For 2 years, and it's like we never really had that sit-down conversation where it was like, okay, hey, it's March 1st, 2010, we're going to start today. And so time kind of gets away from you. And the next thing you know, it has been 2 years and then 3 years, and you wake up one day and suddenly you're in a doctor's office and you're like, is it really to this point yet? You know, have we really exhausted every opportunity? And I was embarrassed, you know, for the longest time. You know, a lot of what we dealt with had to do with me. And as a man, you know, you definitely don't want to hear that. And she obviously had dreams to be a mother and would always tell me that that's what she was born to do. And so, in whatever way I was able to contribute to not that happening was beyond frustrating. I mean, it was
insult to injury, honestly, because it was right around the time that the depression was diagnosed, and then, ooh, you talk about putting salt on the open wound, right? It stung.
It did kind of start to feel like that everything was kind of stacked against you. You know, we had done a few other procedures multiple times. It was impossible not to kind of wonder, you know, hey, is this just in the cards for us?
On my birth,
I had a pretty decent idea of what I was about to witness, but I had, at the end of the day, no clue. I can remember them counting the needles and counting the knives and the tools. And then you don't really know when it starts, but it starts, and then I can remember her shaking. And then you hear somebody cry. And
in that moment, it changed your life.
Then it gets real.
Lost.
You know, you just couldn't imagine, like, it's the beginning of a new journey, but it's the end of this tremendous struggle that we had gone through for so long. And I wrote a song on the new record about them, and that was kind of the most, you know, important part for me of the song, was to let them know, you know, hey, this wasn't just some Tuesday night and we went out to dinner and came home and 9 months later you were here. You know, this was a lot of prayer. This was a lot of people praying, a lot of work, a lot of frustration, anger, fights. You just want them to know that it wasn't easy, but you go through it 15 times just to experience that moment again.
I'm Catherine Nail.
And I'm David Nail.
And this is our fighter story.
I've watched that clip hundreds of times. I still get choked up watching him talk about it. He never says, I had fertility problems, which gives you an idea about how difficult it is to talk about it for some men. But I respect him for having made the video, and it's a pretty powerful piece. Next slide, please. So a couple of other thoughts before we get to discussion. You know, that having a male factor diagnosis is an insult to portions of the psyche that represent your gender and how you feel about it, your sex role identification, and the sense of self. And I think that's true for both men and women, but this is certainly one way that it affects men. Motherhood's a defining role for women in many cultures. Fatherhood is seen frequently as secondary to career, and men have less social pressure to parent. And those are just realities, but that doesn't mean that doesn't have an impact on men when they've been diagnosed, as you could see from David Nail's little presentation. Next slide, please. So that's the sum and substance. There's obviously an awful lot more to talk about when we talk about male factor infertility and how men react to it, and what can be done to help men. But what I'd like to do is bring Dr. Domar into the conversation so that we can have a back and forth and perhaps provide you with some other insights.
Perfect. And I do have a question already coming up, so I'll read this and both of you may be commenting on this question. But the first question is, I didn't expect this to hit me this way. It has. I keep telling myself it's just medical, but it's missing. It's messing with my head more than I thought. Is this normal?
Yeah, I think it's very normal. You know, most of us have this script when we are growing up, which says, I will go to school, I will then find work or a career or more school and then work or a career. I will meet someone, I will fall in love, we will create a family. That's just the normal sequence of things. And when what you believe is the normal sequence of things gets interrupted in such a way, it can be devastating. And that asks an awful lot of us to say, okay, it's not going the way I expected it would. What can I do to fix or find answers to? And sometimes, look, there's infertility, which is unexplained, and that's problematic. We want explanations. And for men, I think the issue is even bigger because we are typically trained to be problem solvers. And when we confront a problem for which we have no solution, that's problematic. I think the same thing is true for men when their wives have fertility problems. You don't have a solution, but you've been trained in many cases to be a solution seeker, a problem solver. And when you can't do that, that can be debilitating.
Ali, would you like to add anything to that?
Well, I've seen a lot of patients with male factor infertility or couples where there's male factor infertility. And, I do think men and women respond quite differently. And it was interesting. This came up a couple days ago. We're doing a research study right now, a randomized controlled trial where we're looking at the impact of a coaching support system for the woman as she starts on the fertility journey. And a question came up that in this particular couple, they were starting by the man, her male partner having treatment, not her. And we hadn't, we had written this whole grant, hadn't really thought about it. And we talked to one of our physicians and he said, the real problem with infertility treatment right now is if you have a male factor diagnosed, 99% of the time, the answer is to make the woman super fertile to compensate for the male factor. And so you're mostly treating the women, even if the woman is reproductively healthy. And so then when you actually sit down with the male partner and they're already feeling, as he said, angry and frustrated and all these feelings about having a male factor infertility. And then he's told, well, we're not going to touch you, but we're going to shoot your wife full of drugs. The guilt he may feel is enormous. I mean, have you seen that, Bill?
Yes, absolutely. I think you're totally right about that. That yes, it's my fault that you're getting those needles, and it's my fault that you're being injected with hormones which are going to cause you to feel all kinds of ways. And it's me, and it's my lack of capacity to do something I always believed I would be able to do, and it would be easy and maybe even enjoyable. And now it is none of those things.
Yeah.
That can be very powerful in a negative way.
And the guilt,
Yep,
just every single shot, every
yep,
single blood test, everything. Because you're in
yep.
effect, I mean, and this has been going on for like 40 years, IVF for male factor, I don't know what's going on in terms of the research in treating male factor and actually treating the men, but it's kind of a sexist way to treat male factor infertility. And
I would agree, it's a very
yeah.
sexist way to do it.
Yeah. And I've had a lot of female patients be pretty unhappy about it, that they are reproductively normal and yet they are turned into a patient.
Yeah.
I think another thing that I see a lot is, I naively had hoped 40 years ago that infertility would come out of the closet, just like breast cancer did. And that, when people were going through infertility, they would tell their friends and people would ask about the diagnosis, et cetera, et cetera. But, I think women are, and there's so many celebrities right now. I mean, just look at Tara Lipinski right now, bopping around talking about her infertility history, and she's on the Today Show every morning. And I really appreciate that.
Hmm.
But, I think women are becoming somewhat more open to
Hmm.
talking about the fact that they have infertility. I think that video is one of the first times I've seen a man come out and say, I have male factor. The reason we're going through infertility is me. And
Yes.
what is it going to take to get men to come out of the closet and talk about, I mean, infertility is a disease. The World Health Organization
Yes.
has said it's a disease.
It's very interesting. About 10 years ago, I was working with an organization that was providing information and a limited amount of support to people. And we did a series of videos about male factor infertility with urologists talking about it. Um, we wanted to get somebody who was prominent, who was well known, to talk about male infertility. We couldn't find anybody who was willing to do that. So then we thought, well, let's get some prominent man to talk about how important family is and why you should be aware of fertility issues. So we went to a National Football League team and we talked with the agents and said, you don't have to say anything about fertility. All we'd like you to do is say, this is really important. Family is important to me. You want to make sure that you take good care of your health. And we couldn't get one of the football players to do it. Now, and we were working with a guy who was doing PR for that particular team, which I won't mention, but it's not the team that Allie's sweatshirt shows. Um,
Everyone
but
see, but I'm from Boston, guys.
but
And
but
let me just tell you, can I just add a PS here is I'm actually physically sitting in Denver because I'm giving a talk here tomorrow morning. And my husband said I was going to risk my life wearing this as I walked through the Denver airport, but I'm still alive.
and we're glad of it.
Thank you.
But that's a problem. Which the
Yeah.
fact that David Nail did that, but you notice he never said I had male factor infertility. He got real close to it, but that's a hard thing for. So
Yeah.
lots of women, prominent women, have talked an awful lot about their own fertility. Not very many men have done that, and
So,
there's a significant number of men with fertility issues.
oh, it's half right now. Half of the causes of infertility are male factor.
Yep.
Arena, do we have any more questions or can I tell
We
a patient
do, we
story?
do. We have quite a few questions. So
Okay.
I'll stop sharing my screen so we can see you both more clearly, if that's okay.
Okay.
But yes, the next question, I think this is quite often that I see this question coming up, but my wife really only wants to have intercourse when she's ovulating. I understand why we are trying to get pregnant, but it started to feel very scheduled and transactional. I feel
Mhm.
weird admitting this, but sometimes it makes me feel more like a tool than a partner. I also feel pressure to perform on demand, and when it doesn't go well, I end up feeling embarrassed, frustrated, or even guilty, like I'm letting her down.
Uh, I don't know about you, Ellie, but I hear this
This
all
is
the
yours.
time.
This is all yours.
Yeah, I hear this all the time. Um, scheduled intercourse. We're lacking in the intimacy that our sexuality gave us before. It's now the job of sex. It's not the joy of sex. And so what we'll frequently do is recommend to couples that there's a fertile window and it's small. And then there's the rest of the month, which happens to be about 4 or 5 times longer than that window. So have relations at other times because you don't want to give that up. We understand how important it is for you to create a family, but we also understand that you came together not just to have a family. You came together because you cared deeply about each other, and presumably there was a physical attraction which you'd like to maintain. And you don't want to feel like sex is just for one purpose. It has, in my view, three purposes. Certainly, family creation,
So,
emotional,
sorry, go ahead. I'm sorry.
emotional connection, and having a good time.
So our colleague Liz Grill, who's a sex therapist, also says, if you have two places where you live where you can have sex, make one place just baby making sex for mid-cycle sex and have fun sex somewhere else.
Absolutely.
Kitchen table, I don't care what it is, but
Right. Or
yeah.
go to a hotel, make
Yeah.
it
Yeah.
really not even risque, just different. And I think that's Liz is very smart and it's really good advice. One place for baby making sex, and then you choose wherever else you want to, because
Right.
you don't if you're thinking about it, what you don't want to do is have the act of being sexually together something which reminds you of not being successful. You want to have successful sex that's not for making a baby at other times in other places.
Thank you both. The next question is, why isn't the DNA fragmentation included in the semen analysis test?
It's a great question. Um, I'll tell a story. I had a recent case where a father had offered to be a donor for his son because the son had a genetic disorder which was out of nowhere, just happened. He's totally not producing sperm. So they ran a semen analysis and everything looked good. And the dad, I was evaluating them for going forward to see if this would have a negative impact on anybody in the two couples. And so he sent me the semen analysis, and all the parameters were reasonably there. And down at the bottom where it says DNA fragmentation, they'd never run it. So what I asked was, why don't you find out why that's never been done? And the answer that came back was, well, they said, you could do 2 or 3 cycles, and then if nothing worked, we'd run a DNA fragmentation. To which I said, you're 70 years old. That ought to be an automatic. So they ran the DNA fragmentation, and DNA fragmentation was 43 to 44%. Well, that's a significant risk. Does it mean that absolutely it would be a problem? No. Does it mean it was an increased risk? And was everybody willing to take that risk? Different story. So it's not terribly expensive relative to the cost of infertility treatment, especially for female procedures. It's $300 to $500 in most markets to do the DNA fragmentation analysis. It just makes sense. Now, if you're 27, you're less likely to run that than if you're 45, because we know that changes take place more frequently with older men. Allie and I have a colleague, Julianne's wife, who's up in Wisconsin, who talks an awful lot about paternal age. And there was a recent seminar that we attended on that very topic. It's significant, but doesn't get talked about enough because mostly we talk about female infertility. We don't talk about male infertility.
Can I just add about that? When you say, have them try for 2 or 3 months, and then if there's no pregnancy, we'll try it again. 2 to 3 months for any couple to lose is agony. I mean, there's
Oh, this wasn't
nothing
two
that
to three
you.
months. This was 2 to 3 cycles. We're going to do 2 to 3 IVF cycles, and then if it fails,
Oh God, that's criminal.
I
That's,
would I would
that's
agree.
$50,000. That's ridiculous.
Of course, for a
Yeah.
$500 test.
Yeah,
Right. Yeah.
ridiculous.
Silly. Really silly.
Thank you both. The next question is, I'm 37 years old, type 1 diabetic. I've been told that I'm the problem in our fertility journey. Is there research that has shown that diabetes causes infertility?
Causing infertility, I'm not aware of any, but I could be wrong about that. But what we do know is that type 1 diabetes has an impact on a number of different systems. Um, so clearly, erectile difficulties can take place as a result of it, and that may be part of the delivery system not working properly.
Maybe
I,
the blood flow.
and it may, yes, blood flow, sure. Peripheral blood flow is compromised in type
Yeah.
1 diabetes. I mean, I'd have to know more before I could give an educated answer about that. But let's assume when you have a systemic problem like that and a progressive disease, that it has some impact.
Mhm.
But I would suggest to anybody who type 1 diabetes whose partner's not getting pregnant should get worked up because, there may be something fixable.
Yes, good point.
Thank you. We have a few more questions. The next one is, again, sex related. Honestly, my sex drive has dropped since all of this started. I feel guilty even saying that. Is this something that you see a lot in couples?
Absolutely. That's incredibly common. Again, sex as a job rather than sex as a joy. Again, with the focus on reproduction as opposed to emotional connection and repeated failures, if you will, that really takes desire out of the situation. It's not being together because it feels good and we enjoy being with each other and we like giving each other pleasure. It's we're coming together because we want to have a baby. And that's not a bad thing, but when it doesn't work over and over again, that takes a lot of desire out of it. This is a stressor. And, Allie is the expert on stress and how it has an impact on fertility, as well as on other functions. And clearly, when you are worried about and stressed by compromised fertility, it's going to have an impact on many things, and desire would certainly be one of them.
I'm thinking between the two of us, we've probably been in practice for like 80 years.
That's
Um,
right.
I'm not sure I can think of a single patient whose sex life was not impacted by infertility.
In
That's
some way.
in
Yeah.
some way.
Yeah.
Yeah, it's very, very common.
Yeah. We think about it. Sex, which is supposed to be enjoyable and bring you together with a partner and fun, no longer has that context with it. That's difficult.
Thank you. You, Dr. Podolak, touched base on adonosperm during your presentation already, but there's a question in follow-up to
Okay.
what you
Sure.
already presented. If donor sperms come up, how do men usually process that emotionally? I don't know if I will be able to handle this.
It's a great question. And I think many, many men have the very same question. Let me tell you about a case that I worked with recently. Um, Not only had he been diagnosed with a male factor, he had had two testicular surgeries to extract sperm with no success whatsoever. So, donor was, if they were going to have a family, using a donor was the next best thing for them because at least one of them would have a genetic connection. And he waffled and he was concerned, and it produced a tremendous amount of anxiety. Will he be ever be able to connect with that child? How will the child be able to bond with him? What will his friends think? All of those kinds of questions came up for him. But at some point, he made the decision, I want to have a family. We want to have a family. I'm going to use a donor. His daughter is 2 years old now. When we were working together before she conceived and before she delivered, we talked an awful lot about how is it that people bond, how do children and parents bond together. And I said to him, bonding is what takes place when you do parenting. And parenting is everything that takes place after the baby arrives. So you're going to have an awful lot of time to bond with your child. And there will be a history that you give about how your child came to be. And that history will be we along the lines of we wanted you very badly. And we found that we were missing one of the parts in order to have you. So we needed a helper, and that helper is called a donor. And we're very grateful to that person. And today, because donors can't be anonymous because of 23andMe and Ancestry.com, it's possible that a child can find out more information about the donor, typically when they're 18. I said, but your child isn't going to want to know who that person is when they're 1 and 2 and 3, when they're establishing the relationship with you. You're going to be the father. You're going to do the fathering. There'll be a genetic component that's not yours, and your child may have a label for that person, but they're not going to call that person dad. And what's going to happen over time is your life will be so focused on what is going on currently with your child that the fact that you used a donor to conceive is going to become less and less important. It will never go away. It's going to be part of your family's history. But as your life with your child goes on, there's going to be so much space that fills in around that it's going to become less and less important over time. So 2 years later, gee, I was right. And he's told me a number of times, we see each other about once every 3 or 4 months just to touch base. And he's, you were right about that, but it was hard for me to believe you before we made the decision, which is totally understandable.
Thank you. The next question is, I definitely agree that men feels like they can't talk about infertility,
Mhm.
myself included. I was looking for a support group and a lot were women only
Right.
groups. So I'm in the same predicament. Any
So,
suggestions? And
It's
sure.
a problem. It's ridiculous that we can't get men to get together to talk about how they're feeling about this.
Well, it's a problem because men either don't have the vocabulary or are uncomfortable doing it. There are a couple of support groups. Resolve, the National Support Network, has one group for men. Um, Maybe it's got two. There at one point there were two. One was led by a professional and one was peer led. So those exist. There's an organization in Great Britain called Men's Fee, which is online, and there's research which suggests that men like an online support network where they don't have to identify themselves by name. You can have a handle, you can hear or read what other men are talking about, and nobody has to know your name. We also know that men who have friends, relatives who have had similar issues and have talked about those issues are more willing to talk with that person because now they share something in common. And it's easier to say, I know you used a donor. I know you had testicular surgery. I know you had trouble conceiving. I am too. But it's really hard to walk up to to your buddy who knows nothing about it and have that conversation. It's important to think about it. Who do we talk to about when we had sex? Typically, it's our partner and nobody else because it's none of their business. But now you're going to discuss a sexual failing, if you will, on your part. Most men don't want to do that. It's a really difficult thing to
Can
do.
we call it a reproductive failing, not a sexual failing? Because men with infertility are just as able to provide sexual gratification to their
Absolutely.
partner.
And to receive it. And so
Yes,
but if you translate it as I've failed sexually because sex is the way that we get pregnant, it
right.
it has both. But you're absolutely
Yes.
right. It's a fertility failure. But it can be conceived of that way, no pun intended. And men will view it that way. So you wouldn't want to say to your buddy, we've had difficulty conceiving because he might hear it as, oh, you can't get it up. Not true at all. So it's more difficult to talk about.
thank you. Ali, I think, the next question we hear as well a lot from female patients, so you most probably will be able to comment here as well. But the next question is, people say things like just relax or joke about fertility, and I don't know how to respond this without snapping. Any advice?
So this has nothing to do with male factor per se. It's just about relaxing and getting pregnant. I mean,
Yeah.
it's a really insulting thing to say. I mean, the fact is, you're saying the infertility is your fault, that the fact that the World Health Organization has decreed that infertility is a disease. Oh, yeah, you've got cancer, just, take a nap and it'll go away. Same thing with infertility. You can't say just relax and you'll get pregnant. On the other hand, there's been a lot more data in the last 5 to 10 years. I've just finished a huge study for which I can't talk about the data yet, where we're getting a lot more information about the relationship between stress and infertility. And so, the problem is by definition, and having infertility is really stressful, and infertility treatment is really stressful. So even if you had a disease that was causing your infertility and the physician treats it or makes it go away, the stress is still there. And so, in all likelihood, if you want to maximize your chances of getting pregnant, you got to combine the best of both worlds, the infertility docs, and then people like Bill and myself who can teach you strategies and coping skills and ways to feel emotionally healthier as your physician makes you physically healthier.
And I would add to that if just relax and everything will be fine worked, Allie and I wouldn't be able to have a job because you would just say something to someone and they'd be able to do it. This is not an easy thing to do. These are
No.
skills to be used and under stressful environments. It takes some work. There's no question about it.
Yeah.
So, on this topic as well, as we're staying on this conversation, can you both please advise the patient how can they find a support, maybe a psychologist in the area who's specializing in fertility, so that they're able to talk to those professionals and get some support? Is there a website you recommend where the patient can look for resources like that?
Well,
Yeah,
we both belong. So the American Society of Reproductive Medicine, ASRM, has a mental health professional group, MHPG, which I believe now has over 700 members.
it does.
And these are men and women and people who are, non-binary, who specialize in working with individuals and couples who are struggling to get pregnant and who know things like what IUI means and CBT and what PGT means and all the stuff that you get thrown at. And they have that specialized training. You can also ask your infertility doctor because almost all of them have mental health professionals they work with. And resolve.org also keeps a list of well-respected mental health professionals. Although I don't even know if I'm listed by Resolve. I need to fix that.
Yeah, really.
There are lots of people out there in the US and in Canada who
Mhm.
have really good skills. I mean, obviously, Bill, his expertise is working with men and male factor infertility. But pretty much, I mean, I've worked with plenty of men with male factor
Right.
infertility. Just because I'm not a guy doesn't mean I can't help a male patient feel better.
No, and I would echo that. The mental health professional group is a place to look. Resolve does have a listing for mental health providers in this area, and go to the clinic. Your clinic staff should know someone who can provide knowledgeable care about the psychological issues involved here. And if they don't have somebody, you should suggest that they get somebody because it's an important part of total patient care.
I will give you a heads up though that Bill is what's the word, a phoenix? What is it when someone is a very rare bird?
I'm an outlier.
There are very few men who specialize in this field. And so unless you were lucky enough to be able to see Dr. Peacock, in all likelihood, even if you have male factor infertility, you're probably going to end up seeing a female therapist. But that doesn't mean that we don't know how to help you feel better.
No, and I would just reinforce that. There are many of my female colleagues who are very adept at treating men because they know an awful lot. If you've been in this field for a while, you can't just learn about female factor infertility. You have to learn about it because it does compose 50% of infertility has got a male factor involved in it.
Thank you. And the last, it's not a question, but I guess it's a statement. Maybe we can both provide an advice on it, and that will conclude our session for today. We argue more now, usually about small things that turns into big things.
Yeah, infertility is really hard. It really hits every aspect of your life and your relationship. And if you're quarreling more and you're more irritable with each other and you're fighting more, it probably means you're having a normal reaction to infertility. But it also doesn't mean you have to continue like that. And I'm saying just see a therapist once or twice who can give you some pointers and tips. And a lot of it's just recognizing how both of you are hurting and you don't know how to comfort the other person when you yourself are hurting.
I think that's a good point. And I would add that it's not unusual for both people in a couple to be in different places at the same time about how they feel. So one may be hopeful and the other despondent, and then that switches. And that doesn't mean you don't care about each other. It just means that you're in different places at the same time. And it's logical because you're different people. you're going to have a different reaction. You're not going to be always in lockstep with your partner. That doesn't mean they're bad. That doesn't mean they don't care. It just means you're in a different place at the same time, and that's complicated. Work with somebody who understands the situation, who can give you some advice how to handle these kinds of things and help you move along.
Thank you both, Dr. Delmar, Dr. Pitok, for your time today. I'm sure
Thank you, Irina, for coordinating this.
Yes, thank you very much. It's been a real pleasure.
Thank you. Very insightful session, and I truly believe that you helped to answer some of the questions for a lot of patients today. So thank you, and have a good evening.
Go
Thank you.
Pats.
I'm going backstage.